Good afternoon everyone. I welcome all the participants for today's National Distance Learning Seminar Series. The session is going to present by Dr. Anwar Parviz Syed on basis of antiretrovirals, tenofovir disoproxil fumarate. And he is a senior medical advisor with the International Training and Education Center for Health, India. In this role, he provides technical assistance to NACO and its Center of Excellence for carrying out various technical and program activities. Dr. Anwar Parviz is a public health specialist and HIV/TB physician. He has early worked at National AIDS Control Organization as regional coordinator in the Care Support and Treatment Division for the states of Maharashtra and Goa. I really appreciate Dr. Anwar for accepting the NDLS invitation. Now I am handing over the mic to Dr. Anwar. Thank you. Thank you so much.
Thank you, Sudarshanan. A very good afternoon to all of you, and welcome again for this session. There are a couple of reasons for which this topic has been selected for today's NDLS, that is only one antiretroviral drug. As you are all aware that now tenofovir is a part of preferred first-line ART from since 2014 now in the National Program of India. So as we are using this drug more and more these days, though we were using this drug in the second-line ART regimen before 2014 also, but as we are using more and more these days, more questions are related to this drug, and especially related to toxicities which are related to tenofovir. This tenofovir disoproxil fumarate is the first nucleotide reverse transcriptase inhibitor licensed for the treatment of HIV infection. So in this session we will be talking about few things regarding class approval dosing, about mechanism of action which will be important for us to understand the toxicities, then the use in the national program as first line and also as a subsequent therapy, few things about resistance and how the second line therapy has been planned, what is the basis for that, then potential adverse effects. We will be talking about the nephrotoxicity in a few more details than others, and also the precautions and risk factors for the toxicity and the other uses of tenofovir. So this drug, as it is a adenosine nucleoside analog and is also active against hepatitis B virus. So given its convenience, that is once a day pill, co-formulations with the other antiretrovirals, relatively good safety profile and also robust antiretroviral activity, tenofovir is currently the most widely prescribed antiretroviral agent, not only in India but across the globe. It is potent against both HIV-1, HIV-2 and also against hepatitis B virus. It is approved by FDA in the year, it was approved by FDA in the year 2001 for the use of combination with other ARVs, and also for the combination of TDF and emtricitabine for the use as pre-exposure prophylaxis. It was approved in the year 2012. We were using tenofovir since 2008-9 in second-line drug as a second-line drug, but as the preferred first line, India's national program or National AIDS Control Program introduced this drug in the year 2014. As far as formulations or the dosing is concerned, we have adult formulation of tenofovir available with us in combination with either lamivudine or in combination with lamivudine and efavirenz. So the dose for that is 300 mg OD, though it has been approved by FDA in pediatric populations of more than 2 years of age. So up till 12 years, 2 to 12 years, it can be given in form of oral powder or tablets, and more than 12 years and weight more than or equal to 35 kg, adult dose can be given. And that is the guideline in our program also, that if age is more than 12 years, we can give tenofovir also. So as far as dosing is concerned, the one which are highlighted or the two combinations highlighted are available in the national program: tenofovir, lamivudine, efavirenz, and tenofovir and lamivudine. You can have or you can get single drug as tenofovir 300 milligram, 150 to 200 are available in the market. Also tenofovir powder for pediatric and tenofovir vaginal gel, that is 1% TDF, is used for prevention purposes. So that is again along with other prevention activities. And other than these, there are other various combinations like emtricitabine with rilpivirine and elbitiravir and others. So, but in the national program, what we have is tenofovir lamivudine efavirenz, that is TLE, and tenofovir and lamivudine, that is TL. If we talk about the pharmacokinetics of the drugs, it is taken orally and bioavailability is about 25%. So after taking 300 milligram orally, maximum serum concentration they reach within 1 hour. Half-life is 17 hours and it persists in the peripheral blood much longer. So it must be taken up by cells to be activated. That means it is usually in inactivated form. I'll come to that in mechanism of action. So it should be activated within the cell to become active. It is eliminated by kidney at two sites and using two mechanisms: glomerular filtration and active tubular secretion. This is about mechanism of action of the drug. This is within the cell. It, as I said before, tenofovir monophosphate is an inactive form, and within the cell it has to be activated and need a diphosphorylation. If you look at the mechanism of action of other NRTIs or nucleoside reverse transcriptase inhibitors, as this is nucleotide, so as other nucleoside reverse transcriptase inhibitor, they need triple phosphorylation, whereas tenofovir needs only diphosphorylation. If we look at the guidelines, the national guideline, the present or current national guidelines, they recommend initiation of tenofovir based first line ART, that is in combination of TLE as a single pill which is taken at bedtime. It is initiated if this in WHO clinical stage 1 or 2, if CD4 is 350 or less than 350, and 3 and 4 irrespective of CD4 or regardless of CD4 count. Though the guideline of less than or equal to 500 has been accepted, but that has not yet been rolled out. As far as pregnant women are concerned, again the TLE is very much safe drug, or tenofovir and lamivudine efavirenz. Also in the first trimester of pregnancy, at all stages, it has been recommended that it should be initiated regardless of CD4 count. Now, why TDF in the first line fixed dose combination? There are various studies which prove that tenofovir is a better drug or superior drug in combination with others, and that justifies its use in the preferred first line. We will see one by one. Tenofovir versus SLE, TLE versus SLE if we see. This study shows that similar rates of viral suppression with 81% in each arm having viral load of less than 50 copies, that is undetectable at 48 weeks. And also tenofovir emtricitabine efavirenz versus zidovudine lamivudine efavirenz, higher rate of viral suppression in tenofovir emtricitabine as well as greater increase in CD4 counts were observed, and lower rate of treatment limiting adverse effect at 48 weeks. In the recent WHO guidelines also it was mentioned that systematic review of 10 randomized controlled trials, they show that tenofovir in combination with efavirenz is superior versus other efavirenz containing regimen on major outcomes. What are those major outcomes? They are occurrence of systemic adverse effects, virologic and immunologic response, and this has high to moderate quality of evidence. So this is sufficient enough to justify its use in the preferred first line ART across the globe. So this is and one regimen which fits all because of its simplicity. That is, regimen is very effective, well tolerated, available as single, once daily, fixed dose combination, and therefore it is easy to prescribe and easy to take for the patients, which ultimately facilitates the adherence. It harmonizes the regimen across the range of population, adult, pregnant women, which even in the first trimester, children more than 3 years, TB, hepatitis B, and also it simplifies the drug procurement for NACO and SACs. It's safe in pregnancy, and efficacy against hepatitis B has been proved. So, and also it is less, there is less risk of hepatic toxicity, and the cost of this drug has been declined significantly since 2010. When this drug was introduced into the national program as preferred first line, there were few instructions which were given to the ART center. I'm sure every one of you working in the ART center is aware of these instructions, but just for a refresher's sake, all new patients who are being initiated on ART, irrespective of hemoglobin, will be given this combination, and all patients who were on TL plus nevirapine or TL plus efavirenz, separate pills, were asked to give TLE as single pill. Those patients who are on TLE due to concomitant ATT, that means in which efavirenz has already been started, they were asked to continue on efavirenz and not to change to nevirapine again. Then stop using TL with separate nevirapine or efavirenz as soon as they receive single, as soon as centers received single fixed dose combination of the TLE. And this TL stock was asked to kept as reserve for use in patients who have HIV-2 infection or HIV-1 and 2 co-infections, and in case a patient if a patient cannot tolerate efavirenz. Now coming to the resistance to tenofovir, tenofovir often retains some degree of activity against HIV strain with resistance to other nucleoside or nucleotide analog, and this is the main reason it is often used in treatment experienced patients. There are two ways to look at it if you want to see the implications of tenofovir resistance for treatment with other antiretrovirals, and if we can see implications of resistance to other antiretrovirals for treatment with tenofovir. So if we see the first, that is implication of the tenofovir resistance for treatment with other retrovirals, the K65R mutation, which is specific to tenofovir, which may be selected by prior nucleoside analog therapy, is associated with a decreased sensitivity to tenofovir. It is also associated with resistance to most other nucleoside analog like zidovudin, but zidovudin, however, retains activity in presence of this mutation. And if we talk about the implication of resistance to other retrovirals for treatment with tenofovir, single or some double thymidine analog mutations, that is single or double TAMs, they do not appear to confer significant tenofovir resistance, right? So, however, in clinical trials, presence of 3 or more thymidine analog resistant mutations is associated with decreased response to tenofovir, particularly if these mutations include the M41L or L210W. Presence of M184V is associated with resistance to lamivudin and imtesitabine, which does not reduce sensitivity to tenofovir. And when it occurs with TAM, it may increase the susceptibility of HIV to tenofovir. So the T69S insertion mutation, this is another mutation associated with resistance to multiple nucleoside analog, are associated with resistance to tenofovir as well, like it causes resistance to other nucleoside analog. So tenofovir should be considered in choosing therapy for individuals experiencing viral recurrence on prior regimen, but resistance testing may be helpful in assessing the utility of tenofovir in individual situations, that is in ideal conditions. Though we are not following that within our national program, but that will be helpful if it is available. And that is how the second line regimen is, or this is how the second line regimen is planned in the National AIDS Control Program. So our current recommendations are based on that if a person fails first line therapy, then a new class of ARV, which is like in most of the cases it will be ritonavir boosted PI, and that is atazanavir or ritonavir or lopinavir is introduced, which is supported by at least one new drug or unused drug, zidovudin or tenofovir or stavudin. Usually tenofovir will be the one, because in all these years our patients were either on zidovudin or stavudin. Then continued lamivudin administration ensures the viral fit test. What it means is, like majority of the patients with failure to first line ART will have M184V mutations, like we saw in the last slide. So continuing 3TC or FTC, that is lamivudin or emtricitabine, will reduce the viral fitness. It will make the virus less fit for survival. That means, in other words, it will kill the virus, or it makes killing of the virus easy. The presence of TAMs, that is thymidine analog mutations, can reduce efficacy of tenofovir, but in presence of M184V mutation, it can reduce this effect and also the effect of TAMs on zidovudin to some effect. And this is how we have our second line regimen into the program for people who fail to zidovudin or stavudin based first line ART. So the regimen which is given will be tenofovir, lamivudin, atazanavir, ritonavir, and in case if a person has developed toxicity to atazanavir, then the atazanavir is substituted with lopinavir. That is in case hepatotoxicity or any severe kind of toxicity. So in ART options for multi-NRTI exposed patients, the Swiss guidelines for patients exposed to stavudin, zidovudin in the past and now on tenofovir based first line ART and failing on the current regimen, if there is no toxicity to tenofovir and no anemia, then zidovudin, lamivudin and boosted PI is given. Now, to understand this, the background which we discussed in the previous slides of the mutations and which mutations are important to be maintained and how these help to make our regimen more active, that knowledge will help. So, in case a person is exposed to stavudin or zidovudin in the past and now currently suppose on tenofovir based regimen and fails, and if there is no toxicity to tenofovir, then new regimen will be zidovudin, lamivudin and boosted PI, that is atazanavir, ritonavir. And if hemoglobin is low, then obviously we will use stavudin in place of zidovudin. And even if suppose we start stavudin, lamivudin and boosted PI, shift to zidovudin as soon as anemia is corrected if there is no history of zidovudin induced anemia in the past, because anyhow we have phased out stavudin because of various reasons, and the zidovudin should be given if there is no history of zidovudin induced anemia in the past. And then substitution guidelines for tenofovir toxicity. Now this will be our actually major point in this presentation to discuss about tenofovir toxicity. So if that happens, then there will be a substitution of the drug, right? In patients, those who were exposed to stavudin or zidovudin in the past but without any virological failure, shift to zidovudin if non-anemic and shift to stavudin if anemic but no history of stavudin induced toxicity in the past. Again, if you start with stavudin, see if you can correct the anemia. If anemia is corrected, then again patient will be shifted on zidovudin if there is no history of zidovudin induced anemia in the past. One message from this slide is, in case of tenofovir toxicity, we will substitute the drug and do not reduce the dose of the drug. or do not adjust the drug. Coming to the toxicities. Now, this is usually well tolerated drug, but may cause nausea, diarrhea, vomiting, like any other many of the ARTs they cause. The specific toxicities or serious toxicities of this drug can be nephrotoxicity, bone toxicity, pancreatitis, and lactic acidosis. There are many others also, but I will not be going in details of each and every, but few major things we will be looking at. Let's see the anatomy and physiology of the kidney before we move ahead, or physiology of the kidney functions before we move ahead, to make our things understand or easier to understand for all of us. If you remember, we have studied the structure called nephron, which is a basic unit of the kidney. It has a glomerulus and also a proximal convoluted tubule. It has glomerulus, afferent arteriole, efferent arteriole, proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting tubule, and collecting duct. For understanding the effect of tenofovir on kidney, these two structures are important for us, that is glomerulus and proximal convoluted tubules. Now, glomerulus is the one which which normally filters the proteins and they are reabsorbed here itself. They are not released into the urine, but the proteins remain into the blood. Now that is the normal mechanism. And proximal convoluted tubules, where the body's vast majority of glucose and phosphate are reabsorbed. Glucose, water, salts, and some other metabolites are filtered through glomerulus, which are passed through proximal convoluted tubules, and they are reabsorbed here. Okay. Now, how tenofovir affects the glomerulus is it makes it leaky, which causes the proteins which are actually reabsorbed to be released into the urine. It causes raise in serum creatinine and lower serum creatinine clearance. Now, this is the one message which is important for many of us to remember, that is, raised serum creatinine is caused by this mechanism. Now, the effect of tenofovir on proximal convoluted tubule is a spilling of glucose and phosphate in urine, which causes glycosuria or hypophosphatemia. That is from here. So, see, tenofovir is taken up at the kidney from blood by the organic anion transporter located in the surface of proximal convoluted tubule, that is here. So after two additional phosphorylations, which we saw in the mechanism of action, the drug is extruded or forced out by the apical multidrug resistant protein, which is also that is MRP transporter, into the tubular space in which urine is formed. So therefore, patients treated with tenofovir may rarely experience any impairment in their glomerular function as checked by measuring serum creatinine or creatinine clearance. And tubular damage may be more common, and indeed case reports of kidney abnormalities on TDF have mainly been reported as Fanconi-like syndrome, which is a typical or which is a type of proximal tubular renal acidosis. So see, the normal renal response to acidemia when it happens is to reabsorb, right? Reabsorb all the filtered bicarbonates and to increase hydrogen excretion primarily by enhancing the excretion of ammonium ions in the urine. But impairment of this mechanism, it causes the renal tubular acidosis. So in the proximal tubule, if we see here, this is a major site for excretion of tenofovir, in short. So, and dysfunction of these proximal convoluted tubules, it leads to wasting of substances in urine, which are normally freely filtered by glomerulus, then reabsorbed by proximal tubule, such as low molecular weight proteins, phosphate, or glucose. So the outcome will be determined by the severity of the insult. If it is more severe, again there will be more symptoms which will be seen. So mild proximal tubule dysfunction may be detected by asymptomatic presence of low molecular weight proteins in the urine, such as retinol binding proteins and all, which are, if available, we can test them, but otherwise proteins in the urine is the mark of, again, injury of this type. Whereas severe disease results in a classical renal Fanconi syndrome, which is characterized by osteomalacia, metabolic acidosis, and glycosuria in absence of hyperglycemia. Now this point need to be remembered here. We will take it again further in a few slides later. So Fanconi syndrome is characterized by osteomalacia, metabolic acidosis, and glycosuria, that is glucose in urine, in absence of hyperglycemia. There is no raised glucose or sugar in the blood, but still a person is having glycosuria, sugar in the urine. So in this study, if we see here, prior to initiation of tenofovir, all patients had serum creatinine concentration within the normal range. But when tenofovir was started, all these patients, see, these are the patients which had tenofovir toxicities, and in those patients, before initiation of tenofovir, creatinine clearance was normal, and once tenofovir was initiated, the estimated GFR, again, it came down, and when it was stopped or following discontinuation of tenofovir, serum creatinine decreased in 95.5% of patients to normal range. What does that mean? That means that if a person is having toxicity to tenofovir, which is shown by raised serum creatinine, and if you stop that drug, substitute with the other suitable drug, then the renal functions, they will come down to normal in 95.5% of the patients. Coming to this again, renal toxicity. Now the things which we discussed just a couple of slides back regarding the ill effects of tenofovir, or the effects of tenofovir on kidney, that will help us to understand the toxicity. Now onset, usually it happens within weeks to months after therapy. I'm sure that people or from our ERT center might have seen this kind of toxicity even before that. But again, more close observation is required once you initiate patient on ART, whether renal parameters are normal, how is the hydration, and all other things need to be seen, and comorbid conditions. But usually it happens within weeks to months after therapy. Proximal tubulopathy leading to Fanconi syndrome. Now this is the main or most common presentation, which is increased to, or proximal tubulopathy is most common presentation. Then increased serum creatinine, blood urea, hypophosphatemia, and then hypokalemia, and glycosuria, and like we discussed before, in absence of hyperglycemia. Then it causes acute tubular necrosis, and it may also cause nephrotic diabetes insipidus and nephrolithiasis. There is this combination, use of didanosine and lopinavir ritonavir, may further increase this risk. Here is a case study. Many of you might have seen this case study during the NACO MO trainings, but it will be worthwhile to go through it again and again. This was from the STM Calcutta, and it is being used in NACO MO training curriculum. This is about 42 years old male, non-diabetic, normotensive male, PLHIV, on second line ART, that is TL atazanavir ritonavir, for 2 years, and gradually progressed to have generalized myalgia with pain in both ankles, knees, hip joints since past 1 year, and its weakness in muscles. Then physical examination was unremarkable, except using crutches in both underarms, and then there was a mild muscular atrophy. lab investigations showed unconjugated hyperbilirubinemia, that is raised bilirubin, and alkaline phosphatase was raised, it was 744 UL. Fasting blood sugar was normal, 86. Then serum creatinine was 1.3 raised. Urine analysis, it revealed proteinuria 1 plus, glycosuria 1 plus, and hemoglobin was 7.8. Uric acid was again 2.4. CD4 was 239. HIV1 plasma viral load was done, which was less than 400 copies. Serum calcium was 8.4, which is low, and decreased serum ionic phosphate, that is 2 mg per deciliter. The radiological examination showed osteopenia of right knee joint and bone mineral density revealed or BMD revealed osteopenia over forearms, bones, lumbar spine, severe osteoporosis over femoral necks. So, like exactly how we define Fanconi syndrome in previous slide, this was the presentation, that a person is having normal blood sugar, having glycosuria, and having lower serum calcium, and then proteinuria and uric acid, and all that which we define the Fanconi syndrome like. So in this case, tenofovir is known to cause rarely Fanconi syndrome and characterized by type 2 renal tubular acidosis in setting of more global proximal tubule dysfunction with impairment of glucose, amino acids, and phosphate reabsorption. So it is typically manifested by hypophosphatemia, proteinuria, normoglycemic glycosuria, hypouricemia, hypokalemia, and raised serum creatinine. So we need to go beyond serum creatinine and look for the other investigations and get it done to label anything as a tenofovir toxicity. So this patient was treated with oral neutral phosphate solution, calcium supplementation, and biphosphonate, and also vitamin D, 60,000 international unit per week. Tenofovir was substituted with abacavir, and patient improved significantly with 3 months with again disappearance of all symptoms, and he was able to walk without crutches. So the take-home message from this slide, from this case, was again, do not re-challenge with tenofovir. If you have toxicity, the ERT center need to find out the cause of abnormal renal functions. And if it is confirmed that tenofovir is the cause, then we cannot re-challenge it with tenofovir again. So we need to be vigilant. In some of the cases, we will see the certain risk factors, and we need to be very vigilant in case, or not only serum creatinine need to be seen, but other parameters also need to be seen wherever it is possible. Of course, it may not be possible in each and every setting to go for each and every investigations, but most of the settings, the simple investigations will be available. So that need to be seen, and if it is proved that now the tenofovir is the culprit, or tenofovir is the cause of the abnormal renal function, then it need to be substituted. It is not to be re-challenged with tenofovir again. So what is the option for substitution? Option 1 is zidovudin with dose modification based on creatinine clearance if HB is more than 9 grams. Why a dose modification? Again, if a person is having compromised renal function, then again zidovudin will be problematic, and we need to reduce dose of zidovudin in such patients. How we need to be given, we'll be seeing in the future slides. Then option 2 is if HB is suppose less than 9, then stavudine need to be used, which needs to be again used in dose modification based on creatinine clearance. We will see how creatinine clearance is calculated. And option 3 is if both zidovudin and stavudin suppose cannot be used, then a person is referred to COE for abacavir based therapy. Why this referral is because our centers do not have this separate abacavir or individual abacavir component without lamivudin. So, but COE has certain provisions for that they can buy from the contingency grant, provided funds are available. So how to monitor such patients whom we initiate on TDF? What our guidelines say is monitor serum creatinine. That is pre-ART we see serum creatinine, then we see after 15 days, and then every 6 months. And based on serum creatinine, we calculate creatinine clearance, that we'll see shortly. But it is not preventing you to again see the other investigations if whenever it is required or applicable. So that need to be done, even though it is not in the guideline, because it is like in general these are the serum creatinine is one of the most important indicator that need to be monitored, or tests that need to be done. But the other investigations are very much applicable whenever that is indicated. So medical officers can use their clinical acumen to decide what investigations needs to be done in what cases. So urine protein creatinine ratio, urine retinol binding protein creatinine ratio, if it is available. Most of the facilities it will not be available, so you can do urine protein creatinine ratio. That is urine protein and serum creatinine and ratio of these. Then fractional excretion of phosphate and glycosuria and serum phosphate need to be seen. So which are the adverse effects that warrant hold of this drug? If you see hypophosphatemia, you need to hold the drug. Increasing creatinine, decreased creatinine clearance, glycosuria without hyperglycemia, lactic acidosis, that is raised serum lactate, dipstick abnormalities, and decrease in bone mineral density in HIV positive people. Consider monitoring if history of pathologic fracture or osteopenia risk, and osteomalacia, that is softening of bones, can also result from Fanconi syndrome. So in all these events, if you see anything, you need to hold the drug and substitute with the appropriate. There are various ways or suggested algorithms. Again, this is not again recommended or given in our national guidelines, but IDSA guidelines say that we can measure the pre-treatment or pre-tenofovir GFR or their creatinine clearance. If it is less than 60, then assess the risk factors for kidney toxicity. If age is more, weight is less, estimated GFR is less than 90, and other renally excreted drugs if a person is taking, then measure every 3 months for 1 year, then biannually. That is estimated GFR, fractional excretion of phosphate, urine protein, urine glucose, and tubular proteinuria if that is available. And if stop drug if significant and sustained changes in 1 to 4 in these 4, and continue monitoring if small increase in 5, that is tubular proteinuria, and if doubt, then nephrologists need to be consulted. Now again, as I said, this is not a protocol of monitoring in the national program, but nobody is stopping you to go for other investigations whenever it is warranted. So basic what we need to perform is look at the serum creatinine before initiation of therapy, then 15 days and every 6 months. That has to be done. And whenever you see any risk factor, you need to be more vigilant, and you need to perform investigations based on the your clinical best decision at that point of time. So creatinine clearance calculation, there are various formulas which you can use. One of the formulas which is given in our national guidelines is by Cockcroft-Gault formula, in which you need to know patient's age, weight, and serum creatinine. And this is the formula, that is 140 minus age in years into weight in kg divided by 72 into serum creat. And if person is or patient is female, then you need to multiply it by 0.85. Now either you can calculate or you can download the apps. These days there are iPhone apps or Android apps which give you creatinine clearance. Just put in age and weight and serum creat, they will give you the creatinine clearance. This is very quick calculations or a quick way of calculating the creatinine clearance. This is how dose adjustment is done in case there is renal insufficiency. Before going for this, Few people they recommend that if you see any toxicity to tenofovir, and there are so many options now are available, and if you are predicting something you can go for the other drugs also, but there are situations in which you cannot avoid giving it, or you cannot avoid going away, and you have to give these drugs in the adjusted doses. So if you see here, if you want to use adjusted doses in renal insufficiency, zidovudin, stavudin, they require dose adjustments. But abacavir, if you see here, they do not require any dose adjustment. So you can give in the same dose. Nevirapine do not require dose adjustment. Efavirenz do not require dose adjustment. And even atazanavir, no dose adjustment is required for patients with renal dysfunction not requiring hemodialysis. Right. And lopinavir again, no dose adjustment is required, but avoid once daily dosing in patients on hemodialysis, and no dose adjustment is required for tenofovir as well, ritonavir as well. So this is how it is adjusted based on creatinine clearance, and of course you will need to have the combination or separate individual drug which will be available with the COE in case you need to give. But again, tenofovir and lamivudine as per creatinine clearance, if you want to see, this is again if creatinine clearance is 30 to 49, 300 milligram OD 48 or every 48 hours, and lamivudine it is 150 milligram OD. Similarly, as and when creatinine clearance goes down, the dose is reduced. From every 48 hours, it is twice a week, and if it is less than 10, it is not recommended at all. In hemodialysis, every 7 days after dialysis, it is given. So you can refer to these charts if you want to give the adjusted dose in case of renal compromise or insufficiency. There are reported liver toxicities also because of this drug, tenofovir. Increased liver enzymes, that is hepatitis, lactic acidosis, severe hepatomegaly with steatosis or fatty liver, we call it as. It can occur with tenofovir use alone or in combination with anti-HIV therapy. It may not have increases in liver enzymes, and majority of the cases are in women, and obesity and prolonged concomitant nucleoside use may be the risks. This drug also causes decrease in bone mineral density via increased bone turnover. The assessment of bone mineral density should be considered for adults and adolescents who have previous history of pathologic bone fracture. That need to be also again asked to patients, and other risk factors for osteoporosis or bone loss. If they are there, then assessment of BMD need to be done. Now, effect of supplementation with calcium and vitamin D was not studied, but such supplementation may be beneficial. So usually this comes in combination. So prescribing this combination will be helpful for such patients. There are various mechanisms which are have been put on to explain the tenofovir related bone toxicity. Three potential mechanisms are preferential uptake of osteoclasts, then uptake of osteoblasts, and uptake by both osteoclasts and osteoblasts. Now these are X-rays of a child, and in this longitudinal study, children were on multiple drug ART, and it is difficult to assign causality of loss of bone mineral density unequivocally to tenofovir. But nevertheless, because patients who discontinue tenofovir while continuing their other drugs showed improvement in bone mineral density, it is likely that tenofovir was responsible for at least some of the observed decreases in bone mineral density. Here you can observe this is pre-treatment or baseline, and here you can see the decreased bone mineral density in post-treatment after 24 weeks. So take home will be tenofovir should be used with caution, especially in children if we are using. Of course, we are not using here, but at least for the age of 10 years or 12 years and more, we use tenofovir. There is a question here. Suppose a patient has deranged renal parameters with high serum creatinine and reduced creatinine clearance values before ART initiation, then which is the preferred regimen? As we discussed before, if it can be corrected before ART initiation, it will be the best option, I would say. And if not, we can use again zidovudine again in corrected doses. But if that cannot be done, then we can go for abacavir also. But in my opinion, again, whatever is the issue with the deranged renal parameters, that need to be corrected if we want to initiate ART or before initiation of ART. Of course, there will be some scenarios where you cannot wait for a long time, and in those cases there will be again reduced doses will be used, where you need to keep in COEs in the loop. So as I mentioned before, calcium and vitamin D supplements will be advantageous. Both substances can also be helpful when osteoporosis is already advanced. Okay. So tenofovir related, again, pancreatitis can happen. It has been reported when used with full dose of didanosine. Obviously, we don't use this combination, and wherever it is available, it should be definitely avoided because it is really toxic. Dose reduction, though it is recommended in the combination, but again, it should not be used. And like other NRTIs, they cause mitochondrial toxicities, which is seen with nucleoside analog. This drug also can cause mitochondrial toxicity. There is potential thought to be lower with tenofovir, that is this lactic acidosis. It is lower with tenofovir as in comparison with DDI, D40, that is stavudine, DDC, and AZT. Fatal lactic acidosis has already also been reported with tenofovir and didanosine, and that is the reason we said before also that it should be avoided. Then severe exacerbations of hepatitis B virus has been reported in patients who have discontinued tenofovir, and minor hepatic function closely, and that is the reason we need to monitor the hepatic functions closely for several months upon discontinuation of therapy. Now, what are the precautions that need to be taken, and what are the risk factors once we can keep a watch on them, and when we start patients on tenofovir? So assess the renal or the creatinine clearance pre-initiation, which we already do, and if it is less than 50, we need to adjust the dose. And monitor creatinine clearance and phosphate in patients at risk. So if the creatinine clearance is high pre-therapy, dose of tenofovir also need to be adjusted. And if that cannot be given, suppose, then it need to be like zidovudine or any other drug. Then avoid drugs that might damage kidneys. Other drugs that might damage kidneys. There are certain risk factors which have been given by many studies, like the more age, and then duration of treatment with tenofovir, that is longer duration with tenofovir, elevated baseline creatinine levels, then treatment with protease or inhibitor or boosted with ritonavir combinations. Some of the other risk factors given by other studies, that is GFR less than 90, used with other medical condition through medications eliminated through renal secretions. For example, acyclovir, which is commonly used, ganciclovir, cidofovir, or adofovir. Then other comorbid diseases, for example, diabetes or hypertension, which also affects kidneys, If there are there, again we can keep a watch on the kidney functions more often in such patients. And ritonavir boosted protease inhibitor regimen, if a person is on, again that can be a risk factor for nephropathy. But see, many people say because of that reason only. See, if GFR is less than 60, it should likely that we should go with the other drugs than to prescribe tenofovir. Because there are nowadays options available with us, so we can use the other option also if the GFR is less than 60 ml. So there are some special uses of tenofovir, like TDF was approved as again drug which can be used again in hepatitis B in the year 2008, and many guidelines they recommend inclusion of TDF plus either lamivudine or emtricitabine in the ART regimen of the people of the patients which are treated for HIV and hepatitis B co-infection. So in many studies it has been shown that addition of tenofovir has been associated with improvement in laboratory markers of hepatitis B progression, and this improvement appears to extend to patients with lamivudine resistant hepatitis B as well. So a small randomized control trial comparison of TDF and adufovir in co-infected patients found that TDF was not inferior to adufovir in reducing hepatitis B DNA levels, and some patients have experienced exacerbations of hepatitis B upon discontinuation of tenofovir, the same which we saw in the previous slide as well. And this is again like a pre-exposure prophylaxis using combination of oral tenofovir and emtricitabine, which is taken daily by HIV uninfected individuals, can reduce the risk of sexual acquisition of HIV. We are not talking about guidelines here, but internationally accepted that it can be given for people who are at risk of acquiring HIV as a pre-exposure prophylaxis. So where tenofovir is given in combination with emtricitabine. So studies which have been performed on MSM in heterosexual men and women, they found that infection risk was reduced by 44% to 73%. So one of these studies also examined the effect of oral tenofovir alone, and it was 62% protective. Another study of a tenofovir gel or vaginal gel found a reduction in HIV infection rates in high-risk heterosexual women. However, in these studies, what we are seeing here, there are other studies also of high-risk women where oral tenofovir and emtricitabine combination and oral tenofovir alone and vaginal tenofovir was used, and they have not shown protective effects. So both that data is available. There are studies which support this and studies which say they are not protective. The reason for this varied study results appear to be like they include differences in the adherence mainly. In these studies that showed protective benefit, effectiveness appeared to be strongly correlated with adherence. Obviously, if adherence is low, then the protection will be again lower. And perhaps tissue penetration of medication and intracellular metabolism also might be a cause of this varied. But by and large, we in our national program do not have pre-exposure prophylaxis. It may come in future, you never know, but that is under discussion yet, so I will not be making any comment on that. Coming to the last slide, so like I mentioned before when I started with the first slide, why this session is again regarding main reason was to, as this drug is being used more and more, we should be aware of all the information possible which will be helpful for us to manage our patients better. So in that we need not, or that is not only regarding measuring serum creatinine, but we need to look at the other factors also. So what we saw in the last 1 hour is like that TDF is a potent drug against HIV-1 and HIV-2 and also hepatitis B as part of preferred first-line ART for adults and adolescents in India. It often retains some degree of activity against HIV strain with resistance to other nucleoside and nucleotide analog, and often is used in treatment experienced patients. That is why you see in the first line and second line also. And last but not the least, tenofovir toxicities should be carefully monitored, and if it is confirmed that tenofovir is the cause of any serious toxicity, then it should be substituted as appropriate. There is no rule of adjustment of doses there. So that is all I think from my side. If you have any, again, I thank you very much for your patient listening and interaction. If I miss any question, I'll get back to you on that. And also, if you have any follow-up questions or if you need any resources related to the data which I presented in this presentation, I'll be happy to provide you that information as well. I hope you know my email ID. It is anwarparvezsyed@gmail.com, or you can WhatsApp me or whatever. So thank you once again, and looking forward for your participation in the future NDLS and RDLS session also. Thank you. A special thanks to Dr. Rajshekharan for his presence and encouragement. Thank you.
Thank you so much, Dr. Anwar, for most valuable session, and thank you all the participants for the patient listening. I request all the participants to kindly enter the e-poll which is displayed on the screen. There is totally 5 questions. I'm requesting all the participants once again to kindly enter e-poll for all the 5 questions. So your comments will be most valuable to us to improve our quality of this NDLS. Thank you.